Welcome. I am Gina Upchurch, and I am the executive director of a program in Durham that's been here over 30 years, and it's really for Durham residents. We are replicating the program in 3 places across the state, and we're going to replicate in 3 more places. We've worked with 3, and we hope to work with 3 more very soon. So this model that you're going to hear about is started in Durham. And I'm the founding director, but it hopes to be in other places. So, and we hope you find it useful. I am also, just in full disclosure, on a group that hasn't been fired yet as a federal employee to advise Congress on Medicare policy. It's called the MedPAC. So I do that. And so that's how I know a lot about some Medicare policy things. So it's just a very part-time job for me, but I don't speak on behalf of the MedPAC, but I do serve with that group. So I just wanted to make that clear. So glad to be with you all. And I'm going to share some slides here and we'll go from there. Please feel free as we're going along to, let me see here, home view, to let's see here, sorry, getting the full version here. Here we go.
And if you want, just raise your hands or put it in the chat, any questions you have, and I'll make sure to give you the opportunity to ask Gina questions.
That would be fantastic. Thank you, because I'm not going to be able to see the chat, but feel free to interrupt me or anything. I tried to make this as simple as possible and as short as possible. Really difficult with healthcare and talking about healthcare and healthcare coverage, but I hope this helps. So the first thing I wanted to orient us to is the growing number of older adults in America. And this is a US-wide statistic, but if you see the gold is the fastest growing group of people, and those are people 85 and older, okay? The next fastest growing is the group 65 and older, and that's in the middle. And then the slowest growing is anywhere from 18 to 64. So what I will say, and I should also say I chair this group at the state level to work on long-term care services and supports in North Carolina. And we're just getting started. It's part of the aging plan for the state of North Carolina. And many of you also may be on the Durham aging plan that Shalisa Howard Martinez leads so well, called Aging Well Durham. So at the federal, state, and local levels, we realize we're unprepared for this, mainly because while we have medical care for older adults, and we spend, as you all know the statistic, twice as much on medical care than other countries, easily. But what you don't often hear is we spend half as much on social care, transportation, food, housing. And we all know that our health is much more than just getting access to a hospital or access to a doctor. It's much more than that. So as people age and they need more care, we have not prepared well for this in our country. Well, what are the growing populations? I thought this was very interesting. We are becoming less white and we are becoming more diverse. Now these projections were made last year. It was a book last year. Now things may have changed because of what happened recently with our election. So who knows how this will shift and that kind of thing. But this was a projection that was made, and you can see massive growth in non-whites, frankly, or mixed race. Obviously, race being a social construct, but it has incredible value in terms of power and who gets to make decisions. So you can see the immigrant population, almost doubling in the next 40 years. So just FYI, I'm going to come back to this later in my talk. Well, where are we growing in numbers of people, of older adults? The darker blue is where you have more older adults. And if you look at this long enough, what you'll see is that urban areas, older adults are often in numbers, obviously, or even as a percentage, many of them are moving, or in rural areas. They're declining is out-migration. People are often moving into more urban areas. Okay. So why does Senior PharMassist care about this? Well, Senior PharMassist is a nonprofit in Durham, independent nonprofit, and we do 4 things to help people. We provide medication therapy management, and that's a pharmacist that goes into somebody's home, they come into our office. We work with providers. We have access to Duke's electronic health record to streamline drug regimens. We provide direct financial assistance. Some people have a card that we have, and they can use this card at any pharmacy to shrink their copayments for medicines covered on our formulary. So if it says that medicine's $50 and we think it should be $5, you'll pay $5, we pay $45. Okay. Tailored community referral. Often when people need help with medications, they need help with other things, often food insecurity or some problems with housing. So we have 3 people on our staff that help people navigate social care. And then lastly, Medicare counseling. Medicare we call the equal opportunity confuser. And we'll talk more about Medicare, but it's just too confusing. We're trying to simplify it. And so we help people navigate their coverage decisions about Medicare. We are the SHIP coordinating site. You may have seen that advertised, Seniors Health Insurance Information. That is, if you call 1-800-Medicare and you say you're in Durham, they give you our phone number. So we are the SHIP site. Okay. So we do these things for different people. So the Medicare counseling is for anybody, any age that lives in Durham, because you can have younger disabled people with disabilities, you can have people with ALS, mental illness. So anybody with Medicare, no charge. We see people to do one-on-one counseling around insurance coverage. Direct financial assistance, though, it's for people 60 and older that have to have a Medicare drug plan. So they have to have Medicare and be in a Medicare drug plan and have incomes below 250% of the federal poverty guidelines. And then tailored referrals, that's for anybody. Somebody needs help navigating X, Y, and Z. Older adults, we'll try to help them get to what they need. We do a lot of Medicaid applications, MQB applications, low-income subsidy applications, or just help navigating general services because it's complex. Our mantra is with better integration between agencies, the individual has to do less navigation, right? So we need to be working more closely together. And lastly, medication therapy management. We have pharmacists trained in geriatrics to streamline those drug regimens. We currently have a contract that goes through the Duke Family Medicine Clinic from the Office of Rural Health to be able to help people up to 300% of the federal poverty guidelines at no charge for that. Okay. When we say community referral and helping people navigate or all of these things, I just want to mention that Senior PharMassist has just entered into a contract with El Centro Hispano to do outreach so that more people know about what we do, and also to hear from the community health workers with El Centro Hispano about what they're hearing for older adults, maybe that aren't even eligible for Medicare, because we don't know a lot about that. So we want to know about that. And so we're just beginning that contract now. Why do we do what we do? Well, Sir Everett Koop says medicines don't work in people who don't take them. And oftentimes that non-adherence is because they can't afford it, right? It's not always the problem. Sometimes people forget, people don't want to take so many medicines, but it's often they can't afford it. The other very big but underrepresented public health problem is that we over-medicate people in the United States. The pharmaceutical industry drives a lot of sales with advertising firms. We take more medicines than people in other countries. We are one of 2 nations that allows direct-to-consumer advertising, TV ads, radio. You can't turn on the TV or listen to the radio without an ad about some drug you need. We over-medicate people. We're less healthy. We take more medicines. 2 countries, us and New Zealand, direct-to-consumer advertising. Other countries don't have that. That's not the only reason we take more medicines, but it's an influence. We take more medicines, we're a lot less healthy. We're ranked 36th overall compared to other developed countries in terms of overall health of our population. but we have all this high technology, all these expensive drugs. Okay. So we like to say you need medicines you need access to, and you need to avoid ones you don't. We call it medication optimization. So that's a big, big part of what we do. We're in the Downtown Senior Center. It's called the Durham Center for Senior Life. So we're a tenant in that building. Anybody can refer for our services. We provide transportation, do Uber Health or the Access vans. We have translation interpretation. We have home visits. We can do telehealth if needed. You see there, we have this new contract with El Centro Hispano to help to make sure more people know about what we do. Okay. To have our direct financial assistance, now we can help people with medicines in other ways, but to get this card, you have to have Medicare first. And so I want to talk a little bit about Medicare. It's confusing, but it comes in 4 parts. Most people pay into payroll taxes or FICA, and they pay Part A. That will be often for people premium free. You can actually use your spouse's benefits too. You may have never worked, or you worked and didn't pay into Social Security. If you're married to someone who is eligible for Medicare, you could use their work history to qualify. Whether you're still married to them, you're divorced from them, or they died, you can use their work history to reach Medicare goals. Part B is the outpatient and what pays physicians, and it pays 80% of the bill. So you still need help for the other 20%. People will often have Medicaid to cover that, or employer coverage or retiree coverage, or they'll often have buy Medigap policy, which we'll talk about. Part C is these things you see heavily advertised, these all-in-one Medicare Advantage plans. If you're not looking at a pharmaceutical ad, you're looking at a Medicare Advantage ad, right? They're all up in the news. They're these all-in-one insurance products for people with Medicare. They're not good or bad, they're different, and we'll talk about that in a minute. And then you have to have a drug plan, or if you don't have a drug plan and you decide to join later and you didn't have what they call creditable coverage, if you didn't have good prescription coverage, you'll pay a late enrollment penalty potentially for the rest of your life. Okay. If you go to a free clinic, I saw Elizabeth on here with Samaritan. If you go to Lincoln Community Health Center to use their pharmacy, they're not considered creditable drug coverage. The VA is, okay? But you got to watch it. What seems like it would be creditable coverage doesn't keep you from owing penalties later if you decide to join a drug plan. That drug plan could be a standalone drug plan or could be embedded in a Medicare Advantage plan. So who is eligible for Medicare? There are a couple of reasons that people could be eligible. It's somewhat similar to Medicaid. And I want to just talk about this for a brief moment. In the United States, you know, we have people, most people have that are working have employer-sponsored coverage. But many jobs don't offer that, right? So people with very limited income and assets can have Medicaid, especially pregnant women, children, elderly, blind, disabled. When we expanded Medicaid, that helped more people in North Carolina, and it's just based on income, not assets, you know, that could get subsidies for Medicaid. And then we have the Affordable Care Act, where people can buy on the marketplace and maybe get subsidies with that. Okay, so that's the Affordable Care Act, employer coverage, but I'm talking specifically about Medicare today. And to be Medicare, you have to be 65 and older or permanently disabled. That means Social Security has said you're permanently disabled. And there's a 2-year waiting list after you are have applied. It goes back to your application date, but 2-year wait period. Plus you start getting that Social Security and there's a brief wait. It's really 25 months from the time you applied to be able to get that. If you have end-stage renal disease, ESRD, or ALS, which is Lou Gehrig's disease also, they immediately qualify someone for Medicare. Okay, so you have to be this category of person, 65 and older, permanently disabled, end-stage renal disease, or ALS, Lou Gehrig's disease. And you need to be a U.S. citizen or a legal permanent resident. Okay. or married to one, right? You can use some of their work history. You'd have to still be 65 and older, but you can use the work history of some people. And you have to have lived in the US for 5 continuous years prior to applying for Medicare. Okay. Now, there are 2 exceptions to this. Some people who are refugees or asylees in the United States, sometimes they're granted after 5 years, usually a 5-year wait period. Not always. There are always special circumstances, but they often will have access to Medicare after a 5-year wait. So asylees and refugees could potentially also be eligible for Medicare. And it's the individual and his or her spouse, again, it could be a current, former, or deceased spouse, needs to have worked in the United States for 10 years or 40 quarters. Say you work for 2 years, you stop for 3 years, you work for 8 years. They add up your work years through the years so that it's 40 quarters. They count it by quarters, 3 months, every 3 months. So during the lifetime, if you or your spouse has paid into Medicare, paid into Social Security, they're called FICA or payroll taxes. All of those things have to be in place for you to be eligible. You have to be one of these categories: citizen, legal resident, sometimes refugees, asylees. They also have special things for people from Haiti and some people from Cuba. So there's some little caveats to this also. So if people are in doubt, they really should call us if they're wondering if they're eligible for Medicare, or the Medicare phone number. Lived in the United States for 5 years continuously, and they have paid into the system for 40 quarters or 10 years. If you have if people that worked not quite 10 years, you still could pay in, but might have to pay a little premium for Part A. Okay, I know this is confusing. So what's the difference? You see these things advertised. Well, traditional or original Medicare is what we had forever. And that's fee for service, meaning the more a provider does for you, the more they get paid, and they just bill for that service. And you have access to many, many providers, because Medicare is widely accepted. 99% of providers will take traditional Medicare, okay? But it comes in parts. You have your A for hospitalization, which is often premium free, but Medicare Part B has a monthly premium. It's $185 a month now. Okay. Some people with limited income and limited assets, cash, things that quickly can be turned to cash. You can own your home, you can own your car, they don't count against you. But some people can get help paying for Part B. It's called Medicare Savings Program. That's our biggest referral, is telling people you don't have to pay that $185. Put that money back in your pocket. Right? People with very high incomes pay more. So if you make over $106,000, you pay more as a single person. But you don't want to be in Medicare without some sort of secondary coverage, because you owe 20% of all the bills, or you go in the hospital, you owe $1,600 deductible. So there's some expenses you could go. We've seen people go broke just with Medicare, traditional Medicare. So you have to have secondary coverage to fill in some of the medical gaps. That can be from a supplement or Medigap policy. It can be from Medicaid, or it can be from an employer, so retiree health coverage. And you need to get a drug benefit. But there are some zero premium Part D plans, or very inexpensive monthly plans with drug coverage. Over half the people in the United States have left traditional Medicare and have gone to all-in-one managed care Medicare Advantage plan. Sometimes when I talk about Medicare Advantage, at the end, people are like, it sounds like Medicare Disadvantage. And, there are some drawbacks to it, and I want to make you aware of them, but they're not bad products as long as you know what you're getting into, right? So it's managed care. It includes A and B. You still have to pay that Part B premium, $185 for most people. It often includes a very good drug benefit, okay? And it has additional benefits, a lot of perks you see advertised. I'm going to show you those in a minute. But what I tell people is you're paying very little monthly other than your Part B premium. But the more you need care, the more you pay. It is pay as you go. You have a co-payment, you have a co-insurance here. Yeah. Co-pay is a flat rate you know ahead of time. Co-insurance is a percentage you pay on the back end after you've seen the provider, okay? So you may not know what that's going to be. if it's 20% of $1,000, that's $200. So you have to pay as you go. They do have a maximum out of pocket, but it can be up to $9,000. So you could still spend a lot of money in a Medicare Advantage plan. When you're healthy, they're wonderful, but when you get sicker and need more care, it can be more and more expensive. There are caps on what you can spend, though. There are networks. You may not be able to go to a rehab facility that you want. You have to go to this one over here. You may not be able to go see this cardiologist. You might have to go see that cardiologist. You may not be able to go to this hospital. You may have to go to that hospital. They create networks. Those networks can change even in the middle of the year. If y'all remember, United and Duke were going at each other and almost split their relationship in the middle of the year. And then you're sort of stuck in many ways until you can get that figured out. So they're networks of who you can see. You pay as you go. And oftentimes they have things called prior authorization, where you have to ask permissions to get X, Y, and Z. The provider has to approve that. So it's called prior authorization. That it's managed care, right? So they're managing the care. Here are all the perks, and this is why many
Gina,
people, yes, ma'am.
There's a question in the chat.
Okay.
So what would be the advantage in Medicare Advantage?
Great question. And let me just go back a slide here if I can.
Mhm.
If you cannot afford secondary coverage, say you didn't work for someone who had an employer plan, so you can't get number 3 down here, and you're not poor, your income is above the Medicaid cutoff, you don't have Medicaid, and a supplement, say, as we get older, or what, at 65, we can get you a supplement for about $100, but as you get older, they go up. So every month you may be paying that extra $100 or the extra up to $200 as you say 85, $250 a month. Some people can't afford that, right? It's super expensive for them. So they say, well, let me save. I don't want to pay an insurance company a monthly rate and I may not even get care. So let me just go to the one where I pay cheap or really nothing other than that $185 monthly, and I'll just pay as I go. So they can't afford that monthly $100, $200 in addition to the $185 coming out. So you just say, let me just take the risk. But the other reason, so that's why a lot of people join Medicare Advantage plans. But the other major reason people join Medicare Advantage plans is this. The other thing I would just say is a huge disadvantage to Medicare Advantage plans is that you better pay attention. Because every year things change. Providers that you can see, how much it costs to see a specialist versus primary care, what rehab facilities work, did the hearing aid benefit disappear? Did you get a cash card last year and it doesn't even work this year where you like to go to the pharmacy? They can change what pharmacies you're able to work. They can change things every year, and they often do. Okay. So at the national level, we're trying to rein some of that in. In fact, at our last meeting, I said, just give people basically HSA. Just give people money on a card. They can decide how they want to use their money towards certain things instead of creating all these programs and hoops people have to jump through. And one year they have to go through this home health agency and they get to know the people. And the next year, in the middle of their treatment, they're having to switch to a different home health agencies. I mean, you just have to be very attentive in a Medicare Advantage plan. If you're in a supplement and you pay your, traditional Medicare, you don't have to worry about it every year. It's the same coverage, same everything. You do need to pay attention to your drug benefit, but your supplement or your retiree coverage often will never change, or retiree coverage is starting to change a little bit, but yeah, Medicaid is great secondary coverage. But you'll see here that a lot of plans have these extra benefits. So look, 100% of Medicare Advantage plans include eye care, eyeglasses, eye exams. Traditional Medicare doesn't cover that. Dental, Medicare will only cover it if you were in some car accident and have a broken jaw or something. They don't cover usual dental care or fitness or hearing exams or eye exams. So many, many people, we pay over $2,000 extra per person for somebody being in a Medicare Advantage plan. This group that I'm on called the MedPAC, think we overpay for these Medicare Advantage plans, and we think many of the insurance companies are pocketing most of the extra money, not giving people these benefits, right? They make you jump through a lot of hoops and change things every year. So we don't have very good data, but what we believe is that a lot of people aren't taking advantage of these benefits, but the insurance company is getting a lot of the money. So we're trying to regulate that a little more closely. So a lot of over-the-counter benefits. And again, traditional Medicare doesn't cover these things. Now, if you have Medicaid, it may provide some wraparound for these things, but traditional Medicare alone does not cover. So you can see why many, many people would be, interested in a Medicare Advantage plan, especially if you cannot afford a supplement. Okay, what about the drug benefit? Well, I'm so excited. It's finally a little simpler, even though it's still not simple. The way that it works is that you get a card, Humana, Aetna, Blue Cross, whoever. You take it to the pharmacy. Be aware, they sometimes call them preferred pharmacies. That's because they often own it and they make more money if you go to their preferred pharmacy. It doesn't necessarily mean you pay less going to a preferred pharmacy. It's very misleading. So if you've got a good relationship with your pharmacist, try to stick with that and find plans that work well with that. Okay. So you get a card, you can pay up to the first $590. Many Medicare Advantage plans waive that deductible. Okay, and they have 0 or no premiums. Standalone drug plans often have that deductible. And then you pay about 25%, sometimes it's a flat copay, until you have paid $2,000. The brand name manufacturer is also contributing about 10% in this period. And at the catastrophic level, the brand manufacturer is giving 20% towards this benefit. But all the individual needs to know is I have a deductible, and then I pay about 25% until I've spent about $2,000. Sometimes a little bit of the brand, it's very confusing, but the maximum you would pay is $2,000 out of your own pocket. Sometimes less than that, okay? Because they count what counts towards the $2,000, sort of complicated. The thing that is exciting, this is all because of the Inflation Reduction Act that was passed in 2022, and the Vice President of the United States came to our office at Senior PharmAssist to announce the Inflation Reduction Act. The huge thing that it did was make the drug manufacturers also contribute to people who had the low income subsidy, LIS. So the drug manufacturers are now contributing to people who even were eligible for the low income subsidy at lower drug prices for the US taxpayers. Okay. There are too many decisions. There are too many options. So if you look at the yellow in 2025, that shows us there are about 12 standalone prescription drug plans. People don't want, and then you look at the Medicare Advantage plans in the blue, okay, Medicare Advantage plans, and sometimes they have a drug benefit, that's an MAPD, and special needs plans. Those are special types of Medicare Advantage plans for people who have Medicare and Medicaid. They're potentially institutionalized, or they have certain chronic conditions. Okay. There are so many plans, and they are confusing to people. So I think we need to streamline people's options. I've never heard somebody tell us that they need more choices about all this. They want more standardization and more transparency, right? So that is one of the messages I'm trying to drive home in some of my meetings. People want more standardization and more transparency. Okay. Low-income subsidy, because the Inflation Reduction Act, massive, big improvement in who qualifies for help paying for their drug benefit. So I've put the amounts here. There's an income guideline as well as an assets test. And again, they don't count your home or your car. Okay. And then people pay much smaller co-payments. So if they have extra help, they don't need Senior PharmAssist financial assistance, but they can receive all of our other benefits. Okay, in order to help people, we have to go to the Medicare website to sort through things with people. So we see people and go through that with them. Last year, during the 7-week open enrollment period, we helped over 1,300 people, and the average mean savings was almost $1,500. That's money back into the pocket of Durham residents, right? and the median was 613. So half the people save more than that, half save less than that. So our tagline is, it pays to compare. When you're looking at, and you know people with Medicare, please send them our way if they're in Durham. And if they're not in Durham, we can help try to navigate them to other places that might be able to help them. We also do other things, but we see them for Medicare counseling. Our clinical pharmacists can intervene if they see drug interactions or see if there's less expensive therapeutic alternatives that we can work with your provider to change. And then our community resource specialists tell people about food assistance, that kind of thing when we see people. Okay. I just want to briefly, and then we're going to open it up to questions and answers. I want to talk a little bit about long-term care. Long-term care is a very general term to describe care that is needed to support a person's basic function. It's not medical. It's what sometimes called custodial care, okay? Medicare, just to make this perfectly clear, Medicare does not cover long-term care. It doesn't. A lot of people are shocked by that news. And again, custodial care is non-medical care with bathing, dressing. But you saw me show that 85 and older, many of them need custodial care, right? Medicare doesn't cover custodial care. Medicare only covers up to 100 days of rehab when somebody needs skilled nursing, PT, or OT. And after 20 days, it's 20 days at no charge usually, and then people have to start paying something, and Medicare covers it for 100. After 100 days, and sometimes people don't even get that far, Medicare stops covering it. Okay, so those people in nursing homes that are long-term stay, Medicare is not covering that. Medicaid is covering that. So Medicaid pays for custodial care in North Carolina, but you have to have a very limited income, or you have to do something called spin down, where your income is above 100%, but you have these big bills because you're in a skilled nursing facility, but your Social Security is here, and they do the math and say you have to spend a certain amount of money, and then the state and the federal government will qualify you for Medicaid. Again, you have to be a legal permanent resident, or you have to be a citizen and have paid into, you or your spouse will have to have been into Medicare, the Medicare system to be eligible for this, if they're dually eligible, have Medicare and Medicaid. Okay. Just so you know, things called assisted living or rest homes, or many of the people getting help in their homes, sometimes it can be paid by Medicaid. If they would have been in an institution otherwise, Medicaid may pick it up, but oftentimes it is private pay. Okay. So who is doing all this care? Who is taking care of all these people? This is what I wanted to show. So this is a recent document talking about the direct care workforce, who is taking care of people as they age, or if they have permanent disabilities or something in their homes or in facilities. Okay. 68%, about 2/3 are US citizens by birth. Okay. 20% or almost 20% are US citizens by naturalization process. And 13% are not US citizens. I actually think this is probably an understatement, because there are many, many people that are paying cash on the side and never reporting who's taking care of them. Okay. And so when we have all this discussion about immigration reform and so on, I am just asking myself, who in the world is going to take care of older adults as we age? Because we know a lot of the direct care workforce, if we're being honest with ourselves, is often immigrants or people who come and are very nurturing to older adults in our country. So I think people just aren't dealing with reality when they have these conversations. I just wanted to bring this up. The Washington Post on April 16th had an article, and I just wanted to, I'm sure some of you have seen it. There's a concern that Medicare, the DOJ and ICE, they're going into some government databases. So they sure enough got CMS and Medicare data, but there's a government database. It's called the Integrated Data Repository, or IDR, and it has beneficiary information, including addresses. Okay. But as you just heard me say, you don't have undocumented immigrants on Medicare. unless they're married to somebody and are qualifying in other ways. So it's like the people that went to look at this database were misinformed about who's even eligible for Medicare, right? So that, you know, they have this big bluster about how they're going to find all these people, and then they're looking in the wrong database. Just no, yeah. The thing I do want to say is that we know that many, many people are using false Social Security numbers in their work situations, and they are paying FICA taxes, Medicare and Social Security, and will not be eligible to receive the benefits, many of them. And so when people talk to me about immigration, I'm like, you know, many people are subsidizing the current system that citizens and legal permanent residents are taking advantage of, Medicare and Social Security. We are being subsidized by people using fake or false Social Security numbers. And everybody knows it, and everybody acts like it doesn't happen. And I just want to point these things out because we do have people who are often the unsung, low-paid, hardworking direct care workers. And at the same time, many of them are paying into a system that is not going to reward them. That was a lot. I am happy to take any questions or comments. And if I don't know the answers, I will try to find them.